की का ही कुछ इशू था। हाँ ठीक है, हो गया, लाइव हो गया। दिखा है, देखा। मेरा तो आ गया कि गोल लाइव हो गया है। आ गया ना। अब मैं स्क्रीन देखना एक बार, मैं ना वो पीपीटी शेयर करता हूँ। अब मेरा दिख रहा है पीपीटी? ठीक है, आपको ही दिख रहा है? अ, हाँ हाँ। Hello everyone, am I audible to all of you? Hi, let's wait few minutes and then we'll start today's discussion. I hope you are all doing well. Let's wait few minutes and then we'll start the session. Are you able to see my screen? Are you able to see the question? Okay, so should we start? Hi, so I am Dr. Milind. You're okay. I'm now able to see all of you. So let us start today's topic and today's discussion. All the questions that you have, you can write in the chat box as well. So today we are going to discuss few questions that are supposed to and they are expected in the in upcoming exam. So if you see the pattern of the last few years, so what we are seeing that pediatrics questions are not very difficult and they are quite easy questions, and predominantly they are asking questions from the general pediatrics. So in today's session, what we are going to do, we are not only going to solve the questions, but we are also going to develop the critical thinking that how should be our approach to the these questions. So the classes that we had, I had tried to stress upon all these points, and if you see the questions over the last few years, they're basically from these areas only. So let's start solve questions. So first question is, poor wound healing is due to deficiency of which of the following vitamin? So let's try to answer this question. Anyone? You can write your answers in chat box. Okay, vitamin C. Can anyone tell me why vitamin C? Can you support your answer? That why do you think it's vitamin C? I Yes. So let's do a little bit discussion about vitamins. Okay. So when we talk about vitamins, so what we say, so so whenever there is a wound healing, so let's try to see few points. So whenever we get an injury, suppose we get a injury or cut on a hand, what happens first? So there is a first we call it primary hemostasis. Means as soon as, again this is a MCQ, not related to vitamins, but again this is a MCQ. So whenever you have a cut injury, what will come to your help first? That is platelets. So your platelets will form the primary plug. Okay, so that is by your platelets. Then the initial bleeding will stop. Then there is a secondary hemostasis. So this secondary hemostasis is by your clotting factors that you have. Okay, so you have lot of clotting factors in your body that will make the clot formation and prevent the further bleeding. Now what happens? Now suppose this was the cut, so the scab is formed, the clotting has already taken place. Now what should happen? The patient, the wound should heal as well. So healing is by the formation of the granulation tissue. So there is a formation of granulation tissue that requires for healing. And this granulation tissue, as someone has rightly said in the chat box, is under the influence of collagen. And out of the options that I have given you, the vitamin that is important for collagen synthesis is vitamin C. And this is the reason your answer is vitamin C. Now, when we look at these vitamins, and whenever I am talking about the clotting factors, let's see which all vitamins and which are things are important during the clotting as well. So I talked about clotting factors, right? So vitamin K is here in the options as well. So can you tell me why vitamin K is important? Why vitamin K is important? Anyone? Which clotting factors are vitamin K dependent? So there are clotting factors in our body from 1 to 13, correct? So vitamin K is important for synthesis of these clotting factors. So can anyone tell me which clotting factors are important for? Yes, Chandini. Yeah, very good. So the answer correctly said. So you have the clotting factors. So you have clotting factors 2, 7, 9, 10. So these four clotting factors are actually dependent on vitamin K. So you will see that this vitamin is also important when it comes to the when we talk about clotting. Okay. Now let's talk about the other vitamins little bit. Okay. Now you tell me vitamin D. If you do not have vitamin D, what will happen? Vitamin D deficiency leads to what? So we have talked about vitamin K, D, C, and vitamin B12. All we are going to talk about. So vitamin K is important for the synthesis of clotting factors 2, 7, 9, 10. Vitamin D. So deficiency, it's also called as sunshine vitamin. So deficiency of vitamin D will lead to rickets. Okay. So rickets is a disease of growing bones. Okay. And as we are discussing here, there are three X-ray uh, findings that we see. Anyone, what are the three X-ray findings, very characteristic X-ray findings that we see in when it comes to rickets? So you see cupping, splaying, and you also say fraying. So remember these three X-ray characteristics that we see when it comes to rickets. So cupping, splaying, and fraying. So cupping is like this. So your bones look like there is a cupping at the top. Splaying means your bones have become like this. There is an angulation that is happening at the bones. And the fraying is like this. There is scattered calcium that is being deposited in your body, because vitamin D is important for absorption of calcium and phosphate in your body. Okay. And lastly, anyone, vitamin B12. First, you guys tell me what is the source of vitamin B12. So which population is prone to have vitamin B12 deficiency? Vitamin B12, yes, very good. So it's an animal source. You don't get vitamin B12 from the any veggies. So those who are strictly vegan, they are at risk of vitamin B12 deficiency. Now tell me, what is the source of vitamin K? So I told you in our classes as well, vitamin K is synthesized by whom? And who are at risk of vitamin K deficiency? Which population? We discussed in our class as well. Yes, very good. So intestinal flora. So our intestinal flora synthesizes vitamin K for us. So which population is at risk? Who needs vitamin K injections? And we give, yes, very good. Infants, newborns, more specifically infants, again, age group of infants is 1 month to 1 year. Newborns are less than 1 month, okay, less than 28 days. So newborns is a better word than infants, okay. So newborns who are they are at risk of vitamin K deficiency because their intestine is sterile. There are no microbes. So that is why at birth what we do, we give them vitamin K. Okay. So this is the reason. So infants are at risk of vitamin K. Now another question for you. Which vitamin deficiency leads to hemolytic disease of newborn? Hemolytic. See, there are two: hemorrhagic disease of newborn and hemolytic disease of newborn. My question is hemolytic disease of newborn. So anyone? So I'm talking about hemolytic disease of newborn, and other disease that you have is hemorrhagic disease of newborn. So hemolytic disease, anyone? On which leads to hemorrhagic. So hemolytic disease of newborn is caused by deficiency of vitamin E for elephant. So these are tocopherols, remember. So I told you they are important for your antioxidant properties. See, whenever there is a infection in the blood or certain medications that you take, what happens? There is a production of these oxidant radicals. They are not good for your RBCs. So your RBCs are killed by these oxidants. So your vitamin E protects you against these oxidants. We also call this antioxidant vitamin. That is your vitamin E. So hemolytic. So when I talk about hemolytic disease of newborn, it is caused because of vitamin E deficiency. Okay, vitamin E deficiency. Whereas hemorrhagic disease of newborn is caused by vitamin K deficiency. Okay. So these are one-liners that you should know about vitamins. Okay, and all the vitamins that we have seen in the question. Now Before you move forward, just few one liners all the of the vitamins that might appear as a question in your exam. So vitamin C deficiency leads to the disease called as scurvy. Okay, and scurvy may what you get, you see gum bleeding, you can have perifollicular hemorrhages. Correct, means you will see the bleeding spots around your hair follicle. Okay, and you can also see delayed wound healing, right? So this is what you should know. Now vitamin B1 deficiency. Vitamin B1 is also called as thiamine. So this deficiency will lead to disease called as beriberi. Just quickly we'll go through the named diseases. Beriberi and the diagnosis test. Just fatafat one liners we'll discuss. Anyone, what is the diagnostic test that is used for vitamin B1 deficiency? So here we check RBC trans ketolase activity. Okay, so we check RBC trans ketolase activity is a diagnostic test for vitamin B1. Okay, now vitamin B3 we have niacin. Anyone, what is vitamin B3 niacin deficiency leads to which disease? So we have pellagra. We have pellagra, which is characterized by diarrhea, dementia, dermatitis. Yes, and some, as some students say, yes, the death as well. The four Ds that we can say. Clear? So these are few important things about the vitamins that you should know. And again, I'm telling you, again, I'm stressing on the part we have discussed in the classes as well. Okay, castles, yes, castles necklace is a part of dermatitis that you see. Okay, so we have discussed in our classes as well that these are the important findings that you should know, and these are the important vitamins that you should know for your exam as well. Okay, now let's come to the next question. Now look at this question and tell me what do you think. So you have to identify the anomaly that you see here. What is the genetic anomaly and what do you see here? And you have to answer the chromosomes that you see that is defective here. Again, this is a common question and very examiner's favorite nowadays. Anyone? Okay, so what we are seeing here. So this line that you see here, this is called as a single palmar crease. So what you can see is a single palmar crease that you see. We also call it a simian crease. And this is a very characteristic of a syndrome that we study, that is Down syndrome. Correct? Okay, so this is a pathognomic. I told you what is pathognomic. You see one characteristic feature and you know what it is. Correct? So this is a Down syndrome. So Down syndrome is diagnosed by karyotyping. Okay, so karyotyping is a method that we follow for diagnosis of Down syndrome. Now, how do you how do you diagnosed by Down syndrome by karyotyping? So karyotyping mein what we get is, when we talk about the Down syndrome, you get trisomy 21. Correct? So what you get is a trisomy 21. See, is it clear for everyone what is karyotyping? So we have the, yes, very good. So we have these chromosome pairs, right? So we have 23 pairs of chromosome. So what happens? So when the body is made, when the egg is fertilized, so what happens? You have 23 pairs of chromosome. They are given some work. You have to do this, you have to do that. Okay. Now what happens? when there is a meiosis. So we studied in our 12th standard there is a meiosis. So whenever we start doing the meiosis, in meiosis the chromosomes fails to separate. So at 21st location you have three chromosomes. So this third chromosome doesn't understand what to do. So it gives the characteristic problems that you see in Down syndrome. So what you get, you have a typical Mongolian slant. So what is Mongolian slant? So this is the outer canthus of your eye. This outer canthus of your eye is upward located, okay, because it is in the center, so it is upward located. Now you have depressed nasal bone, you have simian crease, so you have a single palmar crease that you just saw in the diagram. You have a sandal gap, the gap between your first toe and the second toe is increased. So that is what you see in Down syndrome. So you should know at least the these trisomies and these aneuploidies that we see. So apart from Down syndrome, just as one liners, what we should know is there are some aneuploidies that we should know. So the first is, as we discussed now, we have Down syndrome, which is trisomy 21. Second, we have Patau syndrome. Patau syndrome is anyone trisomy of Patau is trisomy 13. Then you have Edward syndrome. Again, all these are one-liners expected in your exam. Is E for Edwards, E for 18. Then you have Turner syndrome. See, in all other trisomies, what you see is you have the extra chromosome. In Turner's, actually, you have loss of one chromosome. So there is loss of one X. So you have 45X0 because there are 23 pairs, means you should have 46 chromosomes. But in Turner syndrome, the one chromosome is lost. So you have 45XO. Whereas in Klinefelter's, in Klinefelter's, you have 47XXY. So you have a extra chromosome. So instead of 46, you have 47. Remember, Turner syndrome is seen in females, right? And the Klinefelter's is seen in males, that is in boys, because you have Y chromosome here and you have loss of one X that leads to Turner syndrome. Okay? So you should know all these aneuploidies. We call them aneuploidies. Aneuploidy means abnormality of chromosome number. Okay? So this is what you should know. I'm going to share this PDF with you as well after the class. Don't worry, and it will be there on the platform. So okay. So you should all know these trisomies, aneuploidies for your exam. Extremely important. Okay? Clear? Any doubt till now? Anything that you did not understand, you need time to write anything. Okay? So yes, Noonan syndrome, somebody has written in the comment box. So Noonan syndrome is actually a counterpart of Turner in male. Okay, so this kind of thing you see in a male children as well. Clear? Okay. Now let's try to solve the next question. So you have a 3-day old neonate who is exclusively breastfed. Okay, so read question carefully. I always say students, you have to read your question well before hurrying into answer. So he has this persistent vomiting, jaundice, and there is a hypoglycemia, means less sugar. Examination shows there is enlargement of liver, and you check eyes and you find oil drop cataract. So what do you think? Which enzyme you don't see here? Like which enzyme is defective, or which enzymes the patient lacks? So you tell me the diagnosis also first, and you tell me the enzyme that you think is defective. Okay, and what is the diagnosis? And what do you think is the diagnosis? Hello, Kaushik. Yes, very good. So this is yes, yes, and as correctly said by Abhi, so this is a case of classical galactosemia. Okay, so we have studied in the class as well. So what we have? So first, how to approach a question? See, we have a 3-day old neonate. So what does this tell you? So when we talk about a 3-year old neonate, this means the child had something that he has since the birth, something that has started since the birth. But as the child has born healthy, that means there is something that is missing in the child. But mother was taking care of the child when child was in the womb. So that was not the problem. So what it can be? What starts after birth? So breathing starts after birth, feeding starts after birth, correct? So either it's a problem of feeding or it's a problem of breathing, correct? But breathing is very essential, right? So if it is a breathing problem, it will start immediately after birth. 3 days old neonate means 3 days have passed, so you have given adequate feeding. So after giving the feeding, the problem has worsened. So this is something related to the feeding. So you have vomiting, you have jaundice, you have hypoglycemia, means your liver is affected, means the child has definitely some enzyme deficiency that has led to this problem. Now what you have hepatomegaly, you have oil drop cataract. Yes. So why this is happening? Because child is not able to digest the galactose that is in the milk, the lactose and galactose that is there in the milk. So this is a case of classic galactosemia, as you have correctly said. So this is again a metabolic problem. So we have a lot of metabolic diseases that we studied. Classic galactosemia is one of the very common problem that we see. So the enzyme that is absent in the classical galactosemia is galactose 1 phosphate uridyl transferase. That is G1B UT. And galactokinase that you see here, it is responsible for the non-classical form. So you have a non-classical form as well. So this enzyme that you have here, galactokinase, is responsible for the non-classical form, whereas galactose 1 phosphate uridyl transferase leads to classical galactosemia. So what do you see in classical galactosemia? So you have jaundice, you have persistent vomiting that is not going away. Eventually, you have a liver failure, and one pointers to your diagnosis is your oil drop cataract. And what happens this because of the deposition of galactylol. So this excess of galactose gets converted into galactylol, and this galactylol will deposit in your cataract, in your lens. So that gives you the idea, that will make the formation of cataract. Okay. So this is what a classical galactosemia is. Okay, clear? Now I hope things are clear till now. Now let's say few one liners that will give you the clue to the diagnosis. So let's try to summarize 2 3 points. So you have a child who has a blonde hair, child has mental retardation. Okay, so what do you think child has? Anyone? Which enzyme deficiency or which disease? So the clue is blonde hair or a blonde skin and mental retardation. So this is your clue: blonde skin and hair and mental retardation. So all the diseases that we have discussed, because child, what child lacks? Child lacks melanin, right? Melanin, what gives color to our skin. Yes, very good, Chandani. So what we are talking about here is the phenylketonuria. So here we are talking about phenylketonuria, and the enzyme that is deficient is phenylalanine hydroxylase, correct? So the phenylalanine hydroxylase is enzyme. So this is the clue. You will get a blonde hair, blonde skin child with mental retardation. Now you have black discoloration of nose and ear. Also, the child has arthritis. What is the disease? So you have, we also call this onchronosis, correct? So this term is also called as onchronosis. This problem is also called as onchronosis. Black discoloration of nose, ear, and child also has arthritis. Yes. So what we are talking here about is alkaptonuria, and the enzyme that is deficient is homogentisic acid oxidase. Okay. Now, if the examiner says the child has doll-like faces, child has hypoglycemia, child has rhinomegaly, Okay, so this is one scenario. And the second scenario that you are seeing is the child has hypoglycemia and the child has abnormal ECG. So I during our classes also I had given you this clue that whenever you see a ECG and the examiner wants to ask about the okay, the first, yes, very good. So doll-like faces, hypoglycemia, rhinomegaly is one GIRC. That is type 1 glycogen storage disease. That is perfect. Now tell me two. So you have hypoglycemia and abnormal ECG. Like you have the short PR complexes. When you do the ECG, you see hypertrophic obstructive cardiomyopathy. Remember the type 2 glycogen storage disease? Anyone? Rings a bell? Yes, Pompey's. Very good. So you have a Pompey's disease. So as we discussed in our classes as well, so whenever you see ECG, abnormal ECG, so we think about Pompey's disease. And this is what again I want to highlight that whenever we are getting some von Gerk disease, and the second is you have Pompey's. Okay. So we have von Gerk disease and Pompe disease. So von Gerk is type 1 glycogen storage disease and Pompe is type 2. So why I have given you this? So this is because in our notes also we have already discussed this. So whenever you have a clue, you don't have to remember everything about that. You just can get it through the clues as well. Okay. So let's try to solve the next questions. Again, examiner's favorite. This question has appeared at least 2 or 3 times minimum in the last 4 years in FMG, NEET and NICET exam as well. So you have a 2-year-old child has continuous fever, altered sensorium, child has neck rigidity with positive Kerning signs, and the child has an older sister who had pulmonary tuberculosis. You do the CSF analysis. So which of the following findings you are expected to see? So option A tells you about low sugar, low protein, high neutrophils. So first we know that child has altered sensorium, neck rigidity, positive Kerning sign. So we understand the child has meningitis. Now the question is which meningitis? So I'll just try to help you with the clues. So either it's a bacterial meningitis, tubercular meningitis, or a viral meningitis. Now you tell me what. What do you think about this question? So as what is clue here in this question is there is a history in a sister of pulmonary tuberculosis. And pulmonary tuberculosis is infective, right? So we understand this is a tubercular problem is tubercular, right? So there is a high chance the child has a tuberculous meningitis. Now tell me out of ABC which you think is the CSF picture that you see. Okay, so most of you have answered the uh, option B. So let's see what is option B. So let's start from option A. So low sugar, low protein, high neutrophils. Option B is normal sugar, high protein, and lymphocytosis. So let's try to make a small list. So guys, I always tell you, don't make complicated tables. Don't go through complications. Just remember few things. So we have three types of meningitis. So when we talk about the bacterial meningitis, what will be the clue? The clue will be low sugar and you will have the neutrophils. Okay, remember this. Low sugar and neutrophils means bacterial meningitis. Now you have TB meningitis as given in our question. So in TB meningitis, you can have either low or normal sugar. You will have very high proteins. There will be increased proteins that you will see, and the cells you will always see as lymphocytes. Correct? This is what we discussed. And the third, you have viral meningitis that with like what you see in the HSV meningitis. So here usually you have normal sugar. The proteins can be mildly elevated, not high, and you can have the lymphocytes as well. So the major difference that you should be able to do is between bacterial meningitis and TB meningitis. Okay, because viral meningitis can have an overlap, but the major differentiating factor between TB meningitis and viral meningitis is the amount of protein that you see. And see, the examiner will not give you the borderline. He will always give you either a high protein or a uh, low protein wala options. Okay, so you will only be confused between either the bacterial meningitis or a TB meningitis. Okay, that is clear. So again, examiner's favorite, have been asked multiple times. So that is why again I have discussing this particular question. Okay? Clear? Hai? So let's move on to the next question. So as we know, the new drugs are always examiner's favorite. So I think we have discussed in our classes as well, and again we have seen this question repeatedly in last few years. So you have a 4-year-old male child. He's brought to your clinic with complaints of frequent falls. So mother says the child falls frequently whenever even he is walking. He has a pseudo hypertrophy of calf muscles. Calf muscles means your lower leg muscles, okay, the shin muscles, and he faced difficulty in standing up. So when you ask him to get up, he faces difficulty. So what do you think out of the following drug which will be the most useful in the management? So first, as I said, I want diagnosis. Tell me the diagnosis and tell me the drug that is useful. And what is the sign? Yes, Chandani, very good. So we are talking about the Gower sign. So child is having difficulty in climbing, means the difficulty in getting up. Okay. So that is a DMD that we understand. What is DMD? Duchenne's muscular dystrophy. So child is having difficulty in getting up. So we know it's a muscular dystrophy. Muscles are affected. So what happens? It affects your proximal muscles. See, these are my arms. So these are my proximal muscles. My hip are my proximal muscles. Okay? So if I want to lift my hand above this part, my proximal muscles are helpful. When I want to get up, when I'm sitting down, when I want to get up, my proximal muscles are important. So I am able to walk, but my proximal muscles are weak. So what happens? My shin muscles, they try to help me by getting more and more fat in them. So that is why it is called as pseudo hypertrophy of calves. It is not a true hypertrophy, it's a pseudo hypertrophy of calves. So it's affecting the muscles and the protein. Anyone, what is the protein that is affected in DMD? So DMD is a Duchenne's muscular dystrophy. So anyone, what is the protein that we see here? The protein that is defective. So here, what we are seeing here, so we have what are we seeing here is a Gower sign that we are seeing here. Okay, so child is having difficulty in standing up. So that is a Gower sign. Okay, and the diagnosis that we are discussing here is a Duchenne's muscular dystrophy. And the protein, this protein is the largest protein or the largest gene of the humans, that is dystrophin. So dystrophin is the largest gene that is present in the human body, because see, we have so many muscles. So that is why this is the largest gene encoding. So we use one antisense oligonucleotide. So we have this antisense oligonucleotide that we use, which can help. See, I told you during classes also, Duchenne's muscular dystrophy is a genetic disease which is very difficult to treat. There is no definitive management. The management is only supportive. Steroids can help you. Steroids can help you to slow down the progression. Means, for example, the child is 4 year old. So you start steroids. So the disease progression will be slowed but cannot be stopped. So steroids are not used for treating the disease. They just used to delay the progress. Now you have one drug which has been approved by the FDA, which is the antisense oligonucleotide, and this drug in the question is etiplursen. Okay, so this drug etiplursen is an antisense oligonucleotide that is used in the treatment of DMD. So the option here, the answer here is etiplursen. That will be help because it helps. It's like a genetic therapy. So this drug uses used to modify the genes so your muscles don't die. Okay. Now, as we have discussed this, can you also help me to answer the other options? So answer option A and B. So these are also new drugs, nusinersen and avacaftor. Okay. So tell me which is the most common nusinersen is used in which muscular dystrophy? So the option A is again a drug, might be asked in your exam. So you should know all the drugs that are there. See, where the part of the aim of this discussion is also to discuss the other options as well. So can you tell me nusinersen, Spinraza? I told you this is one of the most expensive drug in the world. The total treatment cost is 16 crore Indian rupees only. Remember I talked yes, very good, Elizabeth. So the answer is spinal muscular dystrophy. So nusinersen drug is used for spinal muscular dystrophy, SMA. Remember, I told you it's one of the most difficult, most expensive drug to use. Clear? So nusinersen is used for SMA. SMA is spinal muscular dystrophy. Now evac after, option B, evac after. Somebody already in the chat has said it. Shania has correctly answered already. So ivacaftor is used for the chloride channels. So it acts on the chloride channels. Okay. So ivacaftor acts on the chloride channel. So the drug here that you see, ivacaftor. So here I will write. So nusinersen we use in. So nusinersen is a drug that we use in SMA. That is spinal muscular atrophy. I will just write here. So SMA stands for. So SMA stands for spinal muscular atrophy. Okay, SMA stands for spinal muscular atrophy. Evac after is used for the cystic fibrosis. Correct? Cystic fibrosis, as correctly said. So it acts on a chloride channel. Again, important for your exam. All these drugs. Nusinersen used in SMA. Evac after used for cystic fibrosis. Etiplursen I already told you. What about option D, nitisinan? Have you heard about this drug? The clue is metabolic disease. We just discussed this metabolic disease in the last slide as well. Anyone? So nitisinone is used in alkaptonuria. Okay, this was also a question in few years back. So alkaptonuria, it increases the excretion of homogenetic acid in the urine. So nitisinone is used for alkaptonuria. Okay, so again I will repeat, these are the four new drugs that we should know. Nusinersen is used in spinal muscular atrophy. Ivacaftor used in cystic fibrosis. Etiplursen used in DMD, that is Duchenne's muscular dystrophy. And nitisinone is used in alkaptonuria, which is a metabolic type of disease. We just discussed deficiency of homogenetic acid oxidase. Okay, clear? Okay, very good. Alkaptonuria was the answer. Now let's move on to the sixth question of our discussion. Okay. Now again, this might sound as a old question, but little bit with a twist. The question says, which of the following is a part of diagnostic criteria for defining SAM? Weight for age less than minus 3 standard deviation, MUAC less than 12 centimeter, weight for height less than minus 3 standard deviation, or ascites. Yes, Shania, I'll share the list of that. Okay, so Shania is C, Ayushi C. Anyone else? So enzyme replacement therapy commonly seen in MPS. So mucopolysaccharidosis that we discussed. ERTs are one of the most common indication for using the enzyme replacement therapies. Okay, so let's discuss this question. So which of the following is a diagnostic? So C is something that everybody has said. So let's try to first define the SAM. So whenever we talk about SAM, so first let me uh, let me tell you what the interpretation of that. So the let's go to the first option. So what is this actually? Weight for age less than 3 standard deviation. So when I talk about weight for age that is less than minus 3 standard deviation, we are talking about underweight. So this defines actually severe underweight, right? Okay. So this tells you about severe underweight. When I talk about MUC, what is MUC? MUC is mid upper arm circumference, correct? And how do we define SAM? How do we define SAM? MUC is when it is less than 11.5 centimeter, correct? So if your mid upper arm circumference is less than 11.5, then we call it SAM. So this is not a definition of SAM, correct? And weight for height, the third that you are seeing is a correct answer, because when we talk about weight for height less than minus 3 standard deviation, this is a marker of acute malnutrition. The ascites can be there, but how we have defined the SAM in our notes as edema of nutritional cause, correct? The edema of nutritional cause. Just in the next slide, we will just I'll come back to the slides. Let's define the SAM, because this is a very important definition. So definition of SAM: first, your MUC should be less than 11.5 centimeter. Second, your weight for height should be less than minus 3 standard deviation. And third, you have edema of nutritional cause. So you rule out other causes. Like your liver failure can cause ascites, your heart failure can cause edema, your nephrotic syndrome can cause edema. So if you have any one of the following, so you don't need everything there, you should only have any one of the following. Now another few one liners for you. What is a marker of chronic malnutrition, and what is the marker of acute malnutrition? Chalo batao. So there are two questions for you: the marker of acute malnutrition and marker of chronic malnutrition. So first tell me, what is the marker of acute malnutrition? Height for age? No. Marker of acute malnutrition first. Height for age is a, yes, weight for height is a marker of acute malnutrition. And height for age, as you have correctly said, is a marker of chronic malnutrition. Maybe I have, uh, uh, I mean, read your answer maybe in a wrong way, but I think you are right. You had answered this first. So marker of chronic malnutrition is height for age, because I told you, remember our classes, if you starved for a very long time, what will be affected? Your height more than your weight. And in acute malnutrition, your weight is taken against your height, because height is more stable marker than your age, because your age will change after 3 months, but your height will not change in that speed. So that is why for acute malnutrition, we take it more stable variable, that is height, and we take weight against that. So weight for height is a marker of acute malnutrition, which is again taken in a definition of SAM, and height for age is a marker of chronic malnutrition. Okay? So remember these one liners for your exam, again extremely important for your exam. Okay? Clear? So again, such kind of questions will be asked in an exam, and trust me, in when I talk about pediatrics point of view, the questions that have been asked till now are very easy, and all everything is covered in your notes. So you don't have to go here and there. Just revise this thing, so you should be able to answer this with confidence. Okay. Now, question number 7 in front of you. You have neonate born at 37 weeks of gestation, having gasping breathing efforts. Heart rate is 50 minutes. Child appears blue. So what is the next step in management? So you give positive pressure ventilation, you give surfactant, you start CPR, that is cardiopulmonary resuscitation, or you give adrenaline. What do you do? So again, you have 37-week gestation. He is gasping. Heart rate is 50. What do you do? So do you give positive pressure ventilation, or do you start CPR? So I had uh, during our classes also I had told you this, that okay, I want more people to take attempts. So this is a very you can call it a very twisted question, and this can be a very, there can be a lot of conflicts in this question, because I'll tell you why. So okay, most of you have answered the A. Okay, good enough. So let's try to decode this question. So what I'm saying in this question, that what do you do when a 37-week newborn is having gasping breathing efforts? Okay, so as soon as the baby is out, the heart rate is 50 and the child has appearing the blue. So what is the next step in management? So the baby just delivered, so there is no information that what is happened and what you are doing. So you must remember from our classes also what I had explained you, that see, they have not given you how much time has elapsed after the birth. So newborn who is born at 37 weeks of gestation has a gasping breathing effort. So you don't know whether the child is just born 1 minute, 2 minutes, 3 minutes, 4 minutes, 5 minutes. Heart rate is 50 minutes and child appears blue. So what you are going to do? So again, I have reframed this question. Anyone wants to change the answer, or do you want to stick with the same answer? See, there is no next and best step when it comes to resuscitation. Let me tell you this. Whenever it's an emergency, your next step is your best step, because in emergency you're not going to get time. Okay. So here I told you in the classes as well. Okay. So the answer here would be start CPR. Now I'll tell you why. So we'll just draw a algorithm. Okay. So I had remember. So the baby is born. So baby is born. So we ask three questions: tone, term, and cry. The answer is no. What we do? We stimulate the baby. The first step. Correct. The answer is still no. After stimulation, nothing has happened. What we do? We start positive pressure ventilation. But you must have seen in my algorithm also, which I have given you, and the printed algorithm also. Here the heart rate is always above 100. Okay. So the heart rate is always about 100. And when the answer is no, and the heart rate is still about 100, what we do? We do ventilation correction steps. Correct. And we had in the classes we had discussed the mnemonic that we use is MR SOPA, right? MR SOPA is the mnemonic that we use. Now the child has given you enough time, and now the heart rate falls below 60, and this is when you start CPR. Okay, and if heart rate is still below 60, you give adrenaline. Just remember this simple algorithm. Now what I am trying to tell you here, see, in classes also I have told you one simple line: whenever the heart rate is below 60, start CPR. Whenever, because your positive, your ambu, what the ambu and bag you are doing is a part of your CPR. It's a cardiopulmonary resuscitation, right? So what is pulmonary resuscitation? Pulmonary means you are giving ambu already, but you have to give the chest compressions as well. So if the heart rate is below 60, you do not just give positive pressure ventilation and expect the heart rate to rise. If the heart rate is above 60, and most of the times it's always above 100, because heart rate will not stay between 60 to 100. Either it will go down or it will go up immediately. So the question here, the question that I want to ask you here, now the heart rate has dropped below 60. In our classes I have repeatedly said, they might not be, they will not give you what they have done in between. But whenever you see heart rate below 60, you start CPR. Positive pressure ventilation is a part of CPR. It's a part of cardiopulmonary resuscitation. It's not something else. But just positive pressure ventilation, that does not mean that you are doing CPR. You get my point? So whenever, remember again, in neonates, in neonatology, in whenever a child is born, even after birth, if the heart rate is less than 60, you start CPR. At any, this algorithm that we have just discussed here, the algorithm that we have, what I am showing you here, this algorithm is the line that you follow. This is the order that you follow. But at any step, if you feel the heart rate is here, the heart rate is less than 60. Here, the heart rate is less than 60. You go for CPR. Here, the heart rate is less than 60. You don't think that stimulation will, because that heart rate is too less to start the life. So you do CPR, and I told you your carotid arteries are straight. So you do CPR because your brain centers are alive. Your brain centers are there. So this is the reason. You get my point? So that is the reason why CPR always takes the precedence. The CPR should be the first step that you should be doing. Okay? Okay, the answer is Abhi is asking ki if there is both CPR and adrenaline. So see, again, adrenaline is a part of CPR. So you do CPR, you start doing the CPR. New guidelines say within 2 minutes, you start to 3 minutes of CPR, you give first dose of adrenaline. You continue CPR, you give second dose of adrenaline. So this is a cycle. So CPR always comes first. You start CPR because adrenaline drugs you have to prepare, and this cycle will continue. Okay, so this cycle will continue. So what you do here, so this cycle that is going to continue. So this cycle of CPR and adrenaline is going to continue. So you give CPR, you give adrenaline first dose, you continue CPR second dose, you continue CPR third dose. So this is a cycle that starts with CPR. Clear? So that is why in exam don't do this mistake. Whenever the heart rate is less than 60, see again I am saying positive pressure ventilation is not an incorrect answer, but it is not the best answer. Okay, the best answer here is CPR. So somebody has asked the dose. So dose of adrenaline here that we are going to use, I'll just write a dose. So the dose of adrenaline that we use, so adrenaline that we use is 0.01 mg per kg. So we use 0.01 mg per kg when you use a concentration of 1 as to 1000. So the dose is 0.01 mg per kg of 1 as to 1000. But we do not use it like this. We dilute it in 1 as to 10,000, and the dose we use is 0.1 ml per kg. Okay. So the dose that we use practically is we dilute it with in 9 ml of NS. So it becomes 1 as to 10,000, and dose we use is 0.1 ml per kg because now it is diluted. But in exam, you will get this as an option in mg per kg. Okay. Okay. So let's move on to the next question. So you have a 4-year-old child who has sudden onset violent cough. Child has cyanosis with severe respiratory distress. What is your likely cause? So mother says that child was playing and now he has sudden distress. What do you think? Okay, so let's try to see the pointers. So okay, I have got few answers. So let's try to discuss. Let's try to think that what it can be. See, child is 4 year old. I told you the toddler age group that is between when we say 3 to 6. So they're very curious. So they're always trying to exploring the things. Now, what this question says, the child has sudden onset violent cough. So this question does not say that child had fever, child has cough and coryza. The question says child has suddenly become ill. And now child has cyanosis, means that something that has happened has actually created a lot of problem and severe respiratory distress. So what is the likely cause? So there are only two things that can cause this. One is when you have a foreign body aspiration, and the second thing that can cause this is pneumothorax. Okay, so spontaneous pneumothorax or sign or foreign body aspiration, these are only two things that can cause cyanosis and severe respiratory distress in a child. But usually for pneumothorax, what typical history you will get in your exam is maybe a older child, like adolescent child playing outside, playing football. Football, he was hit by a football in his chest, and then he has sudden this. So you will get this kind of history when it comes to pneumothorax. Okay. Foreign body aspiration, typically toddler age group, they have cyanosis and they have severe respiratory distress. So as I told you in our classes also we discussed. So the right main bronchus is a most common site where the foreign body is aspirated, because your right main bronchus is straight and wider. Correct? What you see on chest X-ray? So you see ipsilateral collapse of lung, plus you see hyperinflammation. Inflation. The other lung says, "Let me do the work for you." So you have hyperinflation of the contralateral lung. So you get hyperinflation. The word I am trying to write here is hyperinflation. So there is a contralateral hyperinflation. Means if the foreign body is on the right side, let's say the foreign body has gone here. So this side's lungs will be collapsed, right? So this side's lungs will be collapsed, and the left side, the lung will be hyperinflated. It will try to help you for doing the breathing work. Okay? So that is what you get in a foreign body aspiration, because it's a sudden onset. Suddenly the airway is blocked. So this history that you get a foreign body aspiration. Okay? Now let's write few points, MCQ related points about the other options. Now bronchiolitis. What do we know about bronchiolitis? So just few things. So bronchiolitis. So bronchiolitis is seen in an age group between 3 months to 2 years. It is caused by RSV virus. Okay. And again, an important MCQ. So you have a monoclonal antibody called as palivizumab. So this palivizumab antibody is against RSV virus. Again, a very important MCQ asked in the past in FMG exam as well. So in bronchiolitis, the monoclonal antibody that you see is palivizumab. Now you have other croup. Croup is caused by parainfluenza A and B. And in next X-ray, what sign you get when we talk about croup? Croup also you commonly see in winters. So when you do a next X-ray, you see stipple sign. So it's like a steeple of the church, correct? So you get a steeple sign that you see in croup. Now, if you see the nematocele, these are the air bubbles in X-ray. So if you see these nematocele in X-ray, what do you think is the common cause? Which bacteria causes nematoceles in X-ray? So when you see a lung, you see a lot of air bubbles in that side of lung. So this is caused by staphylococcal pneumonia, which causes very serious, very severe pneumonia in infants and young children. Okay, clear? Very good. So these are one-liners and things that we should know about the other viruses as well. Okay, clear? Okay. So let's do this is I think okay, second last question of your discussion. So again, important from your exam point of view. So you have this question. So question says you have a pregnant lady in her first trimester of pregnancy. She came in a contact with a child who has bilateral swelling below the ears. So it's a first trimester of pregnancy. Onset of swelling was 3 days back. So what complications you expect in the baby of this mother who came in contact? So the options are cataract, hydrocephalus, PDA, or VSD. Okay, B. Shania says B. And what is the infection and what is the complication that you are seeing? We have discussed this in our classes as well. Yes. So bilateral swelling, not toxoplasmosis. So bilateral swelling below the ears, this is nothing but the what we are talking here is this is mumps. So this is mumps. Okay. So these are mumps. And what mumps they cause is they cause aqueductal stenosis. Okay. So you have this aqueduct between your third and fourth ventricle. So stenosis of this aqueduct, this will leads to hydrocephalus. Again, we have discussed it in our classes as well. So the answer is, as correctly said, hydrocephalus. Okay. So this is mumps. Basically, this mother is going to get infected with the mumps, and mumps cause gliosis of these structures. So gliosis means it's like a scar in your brain. So there's a duct that is aqueduct of Sylvius. So this duct gets blocked. So this duct is between third and fourth ventricle. So this duct gets blocked. So if it is going to get blocked, what is going to happen? The baby will have hydrocephalus. Okay. So let's write down few as we have discussed. Let's write down few congenital infections that are important. So first is congenital rubella syndrome. So we have a triad. So what is a triad of congenital rubella syndrome? So you have cataract plus you have congenital heart disease, and what is the third part? You have hearing defect, that is hearing loss, and this hearing loss is sensory neural type. Yeah, so that is sensory neural hearing loss, SNHL. So congenital rubella syndrome, you have a triad of cataract, congenital heart disease, okay, and hearing loss. Also, you have blueberry muffin rash that we see in a child with congenital rubella syndrome. Okay. Second, you have congenital CMV. So one characteristic thing that you should know about congenital CME. So what does congenital CME cause in baby? What congenital anomaly that you see? Most common, most characteristic. You'll always have this in your option. So what you see is periventricular calcification that you see in the brain. Okay. So this calcification you're going to see in the brain of the child. So you have these ventricles. This is brain, and these are the ventricles, and you see this calcification that is being deposited around these ventricles. So this is a periventricular calcification that you see in congenital, same way as well. Mumps we already talked about. So that is why these congenital infections are extremely important in your exam as well. Okay, clear? Any doubt till now? I'm just giving you one-liners because this should help you as well. Okay. So you should also not go for most of the times what happens, we are very, we want to answer very quickly and we just rapidly go through the answer and we just try to answer fast and move forward. So always read your question well. Okay. So that is what I always tell students. Okay. And the last question of today's discussion is, what is the most common acyanotic heart disease? So you have ASD, VSD, PDA, and TOF. Okay, tell me the full forms also. So let's write down. So I hope this question was easy for you because this is not a very difficult thing. So the first option that we have is ASD. So ASD is atrial septal defect. So this is between your two atriums, correct? Second is your VSD. VSD is ventricular septal defect. And the third you have is PDA, which is patent ductus arteriosus. Okay. And the last you have tetralogy of Fallot. Tetralogy of Fallot. Now, what do you have in tetralogy of Fallot? You have VSD. You have overriding of aorta. You have right ventricular hypertrophy. And the most important of all, the culprit lesion is pulmonary stenosis. Correct? This is a culprit lesion in tetralogy of Fallot. So the cardiac diseases that we talked about are atrial septal defect, ventricular septal defect, patent ductal, uh, not this one, not I, the patent, not patient, the patent ductus arteriosus, and the tetralogy of Fallot. So you have VSD, overriding of aorta, right ventricular hypertrophy, and pavimenosis. So out of these, your VSD is most common acyanotic heart disease. Okay, so this is the most common acyanotic, whereas this one is a most common cyanotic heart disease. What you should know. Okay, clear? So again, this kind of questions that might be asked in your exam as well. Okay, clear? Do you have any doubts and all? This just we wanted to have a brief session with you regarding the questions that are expected in the exam and the question that are I feel that I have seen the patterns over the last few years what we have seen, and these questions which I have made are based on that pattern. Okay, I'll just talk about there are a few doubts in this from the students. So first is TGA. See, in our classes I stressed upon the physiology, the cardiac physiology, the right part, the left part, and all. So whenever you have a question, just close your eyes and think about the question that you have. Think about the physiology, the heart's physiology, right and left. So once you understand the right and left, what is happening, you will understand when it is presenting. So TGA. So someone talked about TGA. TGA stands for transposition of great arteries. Transposition of great arteries. So you have great arteries in your body. So what happens here? So these great arteries are at a different place. So aorta, instead of arising from the left ventricle, arises from the right ventricle, whereas pulmonary artery comes from the left ventricle. So what happens? There are two parallel circulations which are not mixing. So lung is only getting its blood and body is getting only its blood. There is no oxygenated blood going and mixing. So that is why TGA presents at birth in the first day of life. What is PDA? So we discussed the fetal circulation in our classes. Remember the fetal circulation. So where is this PDA located? So when we talked about the PDA, so you remember the slide that we discussed. So this is your aorta, correct? This is your aorta, and this is your pulmonary arteries that are getting separated, and they are going to your. These are your lungs. Okay. So PDA connects these two, the aorta. So your aorta and your pulmonary arteries, or we call it a pulmonary trunk, is connected by the PDA. So this is what PDA is. Correct. Now, why do we have PDA? Because lungs are not functional at birth. When you are they are functional at birth. When you are in mother's womb, lungs are not functional. So this blood flow is obstructed. So this blood should go somewhere. So through PDA, this blood go to the rest of the body. Now what happens once you are born? There is decreased in prostaglandins level and increase in oxygen levels. So that leads to closure of PDA. But in some preterms, this PDA is not closed. Because of that, there is a shunting of blood in diastole and systole. So that leads to hypotension. So blood from aorta coming to the lung unnecessarily. There is increase in left to right circulation. So what you have, the baby will have frequent episodes or apnea. You get continuous. We also call it a machinery murmur. Correct? Also called as machinery murmur that you see. That is a continuous or a machinery murmur. Okay? And you have bounding pulse because the blood is being stolen from the aorta. So you have a bounding pulse, you have continuous machinery murmur, and you have apnea. And remember, this is the PDA is commonly seen in preterms. So we give prostaglandins inhibitors. If the PDA is open, means prostaglandins are there. So the drugs that we use are like endomethacin, and a simple drug like paracetamol can also be helpful, which is a NSAID, PCM, the paracetamol. Okay. Simple paracetamol also we can use, which is a to close the PDA. So it will close, it will stop the stealing of blood from the aorta, so the baby does not have a symptom. Clear? PDA. Okay. And someone has also asked about the dehydration. That is a very good question again. Dehydration is commonly asked in your exam. So we should know the plans of dehydration as well. So let's just briefly discuss the dehydration treatment plans. So you have plan A. Plan A we use for no dehydration. Okay. So what we do here, we replace each loose stool with 5 to 10 ml per kg of ORS. Okay. So it's a very simple strategy. Child does not have any symptom. Child is well, but just having the loose motion. So we use plan A. Plan B is when we use for some dehydration. Correct? So plan B we use for some dehydration. In some dehydration, what are the key factors? The child is thirsty and irritable. Just search for these two words when it comes to plan B. So here what we give, we give 75 ml per kg of ORS over 4 hours, plus plan A is also we use, that is we replace each tool with 5 to 10 ml kg of ORS, and we also give maintenance fluid. Okay, so these are the three components of when it comes to plan B. And the third what you have is plan C. So plan C may we have to give 100 ml per kg of the fluid to the baby. Okay, I'll write the plan C in the next page because this is also important. So I'll just add one slide here. So in plan C, we use in severe dehydration, correct? So plan C we use in severe dehydration. Okay. So what we do here, severe dehydration means child is lethargic, not able to drink. So these will be the pointers. The child is not able to drink, child has lethargy. So total fluid that we give is 100 ml per kg. Now how do we divide? So the it is based on the age group. Child is less than 1 year or more than 1 year. So first we divide into two aliquots. One is 30 ml per kg and the second aliquot is 70 ml per kg. Okay. So for less than 1 year, the child is small, so we want to give it slowly. So the first aliquot we give over 1 hour, and second hour 5 hours. So that will take total 6 hours. And for more than 1 year, the first aliquot is given in 30 minutes, whereas the second is given over 2.5 hours. So here the whole treatment is completed in 3 hours, and here is 6 hours. Okay, I'll again repeat. So plan A, no dehydration. Child has loose motions but no other danger signs. So we just replace each stool with 5 to 10 ml kg of ORS. Plan B, some dehydration. Child is thirsty, irritable, wants fluid. You give 70 ml per kg of ORS over 4 hours. You also keep replacing each loose stool and you give the maintenance fluid as well. And plan C, when it is a severe dehydration. Child is lethargic, not able to drink. So first 100 ml per kg, out of that 30 ml per kg we give in 1 hour in less than 1 year, and 70 ml per kg in 5 hours. Slowly we give fluid. And for more than 1 year, we give first 30 ml per kg in 30 minutes, and next 70 ml per kg in 2.5 hours. Okay. So that is your plan A, B, and C for dehydration and diarrhea. Okay. Clear है? Dehydration, the question, someone had asked question about the dehydration. I hope you have understood the plan. Someone is asking about the why do you want to keep PDA open? Yes. So that is again a very good question. See, why do you need PDA? So again, I told you, just remember the physiology. So again, where, just come to this slide again. So this PDA is between your aorta and your, so I'll again clear the, so you have this aorta again, and you have this pulmonary arteries. Okay. So your PDA is here. This is PDA, correct? So this is your PDA. So why do you want to keep PDA? So if suppose there is this problem with aorta here, so there is a coarctation of aorta. You need PDA open because the blood cannot pass this. So blood can bypass through PDA to the rest of the body. If you have TGA, transposition of the great arteries, how two systems will meet, systemic and pulmonary, through PDA. So when you have a parallel circulation, we call it DTGA. So in TGA, you need PDA to keep open. If you have TAPVC, total anomalous pulmonary venous circulation, the blood is going to the lungs and coming back to the right side of the heart, not going to the left heart. So how it will go to the left heart? Through left side of the part through PDA. Hypoplastic left heart syndrome. So whenever you have such problems where the physiology is altered, you need PDA to be open. Okay. So whenever there's a problem on the either side, left or right, and the mixing of blood is not happening, then we need PDA to keep it open. And yes, the prostaglandin analogs like alpostadil are used to keep it open. Okay. So this is when you need for duct to stay open to save the child. I told we discussed in TGA the emergency treatment, the first treatment. So in that case, see, when it comes to TGA, when they ask you what is the next step in this child, so the next step is PG, prostaglandin transfusion. In TGA, what is the best next step? But if they ask you what is the treatment of choice or the best treatment for TGA, that is arterial switch. That is Jatain's arterial repair that we discussed. So there is a difference between the next step and the best step. So the next step in TGA, first you give prostaglandin infusion. Second, you do Rashkind's atrial septostomy. Again, we discussed in our classes. You break the atrium and make a temporary ASD, atrial septal defect. You prepare that temporary defect so the blood can mix. And the definitive is arterial switch. That is Jatain's arterial switch. Clear? So this is what you need PDF for. And this is why again in my classes I have again stressed upon the physiology, because if you know physiology, no matter how they twist the question, you will be able to answer that. Okay? Clear? Do you have any more questions for me? I hope this session was helpful for you, because I wanted to address two things. First, again, as the exam is approaching, how the approach should be to the question, and just to stimulate little bit of your critical thinking. Because as I again have been saying to my classes, half battle is done. Half battle is preparing for the exam, reading your notes that you have been doing. The half battle is attempting your question, attempting your exam. Just stay calm, read your questions well. Don't be confidence is good, but don't overthink, don't underthink. Just attempt a good paper, give adequate time to all the questions, and I'm sure you all will do well. And I'll definitely see you all soon on the other side. So I have already shared the details as well. If you have any doubts regarding this session as well, you can always write. You can through the group, and we will reach you through that as well. So thank you all. Thank you so much for joining this session, and I hope this was definitely helpful for you. And we'll definitely meet again for another session. Thank you.